Hi, everybody. I'm Dr. David Granite, and welcome to Health Matters. It's estimated that 50% of us will have some sort of sexual dysfunction or problem in our lifetime, and that in the last year, some 40% of women and 30% of men had some sexually related problem. This is a big deal. This affects us both in our private lives and in the way we feel about ourselves in our public life. We need some help to get through this topic. And to get us to this topic, we have an internationally renowned sexual medicine expert, Dr. Irwin Goldstein. Welcome.
God bless you. I loved your introduction, by the way. I can listen to it all day. Well, keep saying that stuff.
Dr. Goldstein is chief of the Division of Sexual Medicine
at Alvarado Hospital
here in San Diego.
The first.
And that's amazing that it's the first of its kind, because you would think that everybody had a department of sexual medicine.
We don't have it anywhere. UCI, UCSD, UCLA, Harvard, every place. Nobody has this.
And so with this being an integral part of everybody's life,
yes.
As we become adults, this is part of who we are and what we do. How could it not be a department that is standard that everyone has?
God, I wish I could take you with me. Nobody wants it. I mean, it's hidden in different departments. It's hidden in urology, it's hidden in gynecology, it's hidden in endocrinology, it's hidden in psychology and psychiatry. It's a taboo subject, is basically the issue.
It's one of those taboo things that everybody does.
That's a good point.
It's sort of an oxymoron to think that we don't talk about.
Yeah, but you don't talk
about
it. Yeah.
Well,
you do it, but it's like don't ask, don't tell.
Yeah. Well, but that's the purpose of our show today, is to talk about this a little bit. And I think that let's start with where we are right now, and that is we're talking about a department of sexual medicine. You ran through a list of doctors that people might think to go to when they have a problem, and we're going to talk about the problems in a minute. I would think that men would go to a urologist and women would go to their OBGYN. What's wrong with that?
But only 6% of urologists, and I'll say 6% of gynecologists, have really any interest in this area.
So when the average person with a problem, an average guy with a problem, goes to the urologist, makes an appointment, thinking this is the specialist, what are they going to get?
A 7-minute visit that ends with a prescription for a pill.
And no real discussion of the underlying issues or problems that might be leading to this, or even recognition that this might be heralding other problems.
Boy, everything you're saying is so great. I hope we have time to go through every
We're going to.
Yes,
I prepare for these shows. I don't just show up.
No, but everything you're saying is right. You can't do sexual medicine in 7 minutes, and you need to see a specialist. It's almost... I mean, you're a pediatric ophthalmologist. Strabismus isn't going to be done at a primary care level, and I don't know how many millions of people have strabismus. There are many parallels to sort of what we do together. There's headache specialists. There's people who have difficult pregnancies. There's people who have, I mean, at some level, you want to get your thoughts and feelings about a very private part of your life, but you don't want to do it in an office with 50 people and you have 7 minutes, and it's mostly done by a nurse practitioner anyways. So it doesn't work.
I would think that if you are a married couple, that one person's problem is both persons' problems.
Oh, God. God, you're good. This goes back to Masters and Johnson. You can't have a sexual problem, impotence, for a guy, very common discussed issue. It has to affect the woman. And a man who has a prostate cancer operation, where the overwhelming chances are he's going to have a sexual problem at the end of it. No one discusses the issue about the women. 60% of women, when you actually study them, lose their own sexual function, and they never even had the prostate cancer surgery.
It's an incredible number when you think about it, the changes that take place. 60% of women
will have different desire, arousal, orgasmic potential, and even develop pain during sexual activity because the man had a prostate cancer operation.
I mean, so how can you have...
the other way around. Women who leak urine and have difficulty with their sexual response will cause men to have sexual problems, specifically impotence.
So it's a couple issue.
Yes.
Okay. And as you said, this is not news.
And couple issue, infertility. I mean, you must appreciate there are people who can't have babies. It's so recognized. The man goes with the woman for that evaluation. Okay? But when you have a sexual problem, the guy goes without the woman, and the woman goes without the guy.
It's part of what I was thinking while we were talking to you. My wife and I went through 17 cycles of in vitro fertilization, having had difficulty conceiving our second and third child.
But you both went?
Every time.
Right.
As much as we possibly could.
And it was natural, and it was expected, and you shared each other's issues.
Yes, and the reproductive endocrinologist always talked about it as our issues.
So how many women go with their man so they can get their sort of Viagra-like drug?
I have no idea.
Yeah, I could share with you.
Okay.
Very few.
Okay, so
That's his problem.
Let's put this in context.
Okay.
The only way I know that people talk about this is if you're watching a football game and a commercial comes on. Right? I mean, there's a commercial
and the only thing they remember about the commercial? Is that if you have an erection for 4 hours, go see your doctor.
Which is
for whatever reason, that resonates.
It's the greatest advertisement in history when they talk about the complication. Right, exactly. So
I want that 4-hour erection.
Yes. So we've already hit on so many things, oblique that I wanted to talk about, which is quality of life. The impact it has on your relationship. But what about and we're talking about this in general if you have sexual problems. We haven't talked about specifics yet. What does that do to you when you get up in the morning and go to work? How you feel about yourself, your confidence in the workplace, your ability to interact with other humans when you know at home you're having these issues?
Well, you bring up some very fascinating points. You would think it would affect most people, but actually only in the range of a quarter of people are really bothered by this. So, a 67-year-old guy with poor erections, if his wife is sort of sexually retired, they play golf. They go out to dinner, they hug, they cuddle, they go for walks. I mean, their sexual expression has changed, and they adapt to it. There are people who are really distressed, but it's really only a quarter. And we haven't figured that out yet, and we don't think it would be the same value if there were more therapies. Like, for example, there isn't a drug-approved therapy for a woman with sexual problems, yet women have more sexual problems than men. So we think there would be more bother if, some people just resign.
Well, I guess that's where the friendship of a couple becomes very important as well.
Well, you become brothers and sisters. That's okay to some people. It's not okay to everybody.
To everybody, right. Well, let's talk about something that I think is really important. A satisfying sex life isn't just fun. There are issues about your health, longevity. Can you speak about those? Sexual
issues are really the early warning sign for medical problems. When you have, the artery in your penis. How big is the artery in your penis? As you're sitting here now, having this interview. In
pinky size? I don't know. I'm guessing.
It's 1 millimeter or less.
Okay, there we go.
Okay, so that's like a fifth the size of the artery to your heart. So if you walked in a doctor's office and said, "Oh, I have chest pain and it travels down my left hand here," you'd say, "Oh God, we got to go to the emergency room." Or versus, you go to a doctor's office and say, "Gee, I can't get an erection." He'd say, "Oh, it's in your head. Go on vacation."
Right.
Where what's really happening is the same artery, different size, is getting blocked in a large percentage of cases, and the angina of the penis is impotence. The angina of the heart is more viewed on as important.
What a great phrase, angina of the penis. I mean, that puts it in perspective. Well, is it then the canary in the mine? I mean, this is the first red flag to tell you that there's something going wrong with someone's cardiovascular system if they have erectile dysfunction. Could it be?
Not just could it be, it is. I mean, Journal of the American Medical Association took healthy people without risk of cardiovascular disease and followed them for 10 years, part of a prostate cancer study. The cohort were the controls. So they looked at if and when, during those 10 years, someone complained of erection problems, when he had a significant cardiac event, heart attack or stroke or cardiovascular death. Okay, at 7 years, something like 15% of this healthy population had a heart attack or stroke. Impotence is the early warning sign. The condition of impotence is as important to a heart attack as is family history or cigarette smoking. I mean, it's a relevant risk factor.
So if someone sees their urologist and they get a prescription for a medication for impotence,
you're missing half the path.
And they're not sent for the cardiovascular workup or not surveyed on a regular basis to make sure they're okay. Right. Not only missing half the battle, I mean, it could be death.
Well, okay. It's an early warning sign, yes.
I mean, these are high-risk patients.
The two paths are get your sex life better and go find out why your sex life isn't good.
And I would think that if I'm a patient in that setting, the sex life is obviously very important, but I don't want to have a stroke, heart attack, etc.
Right.
I mean, so
nobody wants that.
I feel like that's an enormous second path that's missed.
If you walk down the halls of UCSD to the coronary care unit, okay, and the people are lying there and beep, 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 and nobody's happy, and you went up saying, hey, I'm doing a research project, I'm sorry you had your heart attack, but it's just going to ask you a question. Did you have impotence 3, 4, 5, 7 years before this? What do you think the answer would be?
You know, now that we're talking, I'm guessing it's going to be 30. Okay,
no, 95% have had impotence preceding their heart attack. It is an early warning sign missed by contemporary physicians. It hasn't captured their being yet.
I would think that every cardiologist, internal medicine doctor would need to have that on their checklist of review of symptoms.
Asking about their sexual health is paramount to understanding the integrity of that man's vascular tree.
Incredible.
But impotence happens without vascular reasons.
Sure.
There are hormonal reasons, there's surgical reasons, pills and medicines.
It's a risk factor, understood.
Bicycle riding here in Southern California.
One of the things we want to get to.
I can't tell you how many kids I see.
Yeah, well, as long as we're talking about erectile dysfunction and impotence, what is erectile dysfunction? Because other than television commercials, most people don't know, or Bob Dole, getting up in front of the camera, most people don't know.
Well, we have NIH definitions, so it's persistent or consistent inability to obtain and or maintain a satisfactory erection. I don't know. That's the phrase. Basically,
but that might be different to each person.
That's my point. It's in the eyes of the beholder.
Okay. And so what are the basic causes of impotence or of erectile dysfunction?
Well, classically psychologic and biologic. And the biologic are nerve issues, hormone issues, or blood flow issues. Medication issues, anatomic issues. I mean, we could get broader, but those are the classics.
So there are some medications that people take that could affect their ability to maintain and get an erection.
What's the most common one?
I'm an ophthalmologist. You're asking me these questions.
Think.
I have
depression.
SSRIs.
SSRIs, they kill erections. Right. So the SSRIs, the S, raises serotonin, a anti-sexual neurotransmitter in the brain.
And these days, there are a whole lot of people on SSRIs.
Oh, my God. And especially more commonly women than men.
I'm thinking if I'm depressed and I take a pill and now I can't get an erection, that's not helping my depression.
I have to stick this in right now, okay? The women who take birth control pills, there's only 300 million women. Everyone on a birth control pill must, by guarantee of the physiology of their drug, have low testosterone. A large percentage of women with low testosterone get depression. Not the classic depression, but a actually pharmaceutically mediated depression.
So we're not going to go through this in an organized way. We're just going to jump around.
By the way, guess what? Guess what? 1/3 of the women who walk in my office are taking both birth control pill and
SSRI.
Because they're have depressed. Doubly pharmacologically changed their sex life. We lowered their testosterone with one because we're using drugs that we're trying to buy some contraception benefit, but they're playing with hormones. They're playing with these developing bodies are not getting normal hormones anymore. So then they become depressed and they twice.
See, to me, we've circled back around to the whole idea of having a Department of Sexual Medicine because, you go to, pull it out. So let's see. This is the ID that says sexual medicine, and it's a lifetime of developing that, right? I mean, that's to have those words on there, right? But the reason why I'm bringing this up is because if I go to my OBGYN and get my birth control pills.
Very limited discussion.
And now I develop depression, and I go see my internal medicine doc, who these days writes the SSRI. They're not talking to me about my birth control pill. Right. The OBGYN is not finding out that I have depression. Even if they would ever connect it, they're not, because they're not. The conversations don't even go to the same person.
Right. We need education. Education. We need this in the medical schools. See, a department would get it into the medical schools. We had 10 hours a year in my previous place in medical students. They were amazed at information.
Well, it's connecting.
Doesn't exist here at UCSD.
To me, I mean, I've spent a big part of my career connecting things that people don't put together, and you're connecting these things.
Like the eye, the vectors. I mean,
absolutely.
We have bent penises. I mean, it's all vectors. It's the same concept.
You've written books, right? I mean, this is
300 books.
The Potent Male. I mean, these are.
Let's do this
important.
one.
This is the Journal of Sexual Medicine.
Journal of our field, the Journal of Sexual Medicine.
The official journal of the International Society for Sexual Medicine.
It's out of the
Volume 5, number 11.
The editorship happens here in San Diego.
Is that you?
Really exciting. Yes.
Yes, which is, again, this is how you make a difference.
Yes.
You get these articles in print, you get the books in print, and you educate people about it. Well, let's continue educating people. We started with this conversation with erectile dysfunction. We talked about how people know about a pill. When is a pill appropriate? When is a pill not appropriate?
Wow. You're talking women and contraception?
Well, we're starting with erectile dysfunction.
Okay. Oh, that pill.
That's the one that you see in the television
it's
commercials.
extremely successful. The Viagra, Levitra, Cialis version. By the way, we're just doing a clinical trial for a number 4 version of these agents, PD5 inhibitors. So they're historically exciting and now being used in other fields. So very cool. The thing is, they work, so that's good.
So if I have a psychological cause for my erectile, dysfunction, will the pill work?
Actually, it would.
But it doesn't get to my underlying psychological issues.
Correct.
Does it make me feel better anyway?
Yes.
And does it actually eventually help turn around psychological issues?
It could. But again, you need to get at the underlying cause if the pill doesn't resolve the issue. But that's psychology, and then there's biology. So if the problem is a low testosterone, you're still not addressing the issue. If the problem is blood flow, not only do you really want to address it because you don't want the consequences later.
Right. So that script by a urologist, and we're not knocking all urologists, I mean, but if you give it a script...
Yeah, healthcare provider.
Well, by someone who gives you that prescription for...
More scripts come from family doctors than urologists.
For one of these drugs, and they haven't looked at your testosterone levels. They haven't really tried to identify your psychological issues. They are covering something without fixing it.
Right.
I mean, the underlying problems have been ignored.
Let's be logical here. A lot of people come in knowing they have high blood pressure and hypertension and high cholesterol, and they have sexual problems because that's almost a guaranteed issue.
Right.
For those people where we don't know what it is, and it's not obvious, and to walk away with a script is not in their best interest. I mean, it's in their best interest at the moment.
So if it's the unknown cause, obviously, that makes more sense to do that. I was just thinking about that 67-year-old man who gets the Viagra, but his wife is at a different stage, or has got a declining interest in sexual matters, and after postmenopause, because there are changes that take place, normal changes that take place. Now you've got a disconnect, right?
Right.
What happens?
Well, you had infertility. You went with your wife, God bless you, and you know what that's like. So a guy's taking Viagra, and his wife says, I don't want you to take Viagra. It hurts. I'm not interested. I have other things I want to do. He could have a conversation, okay, we're both done. If you're done, then I'm done. Or, don't you think we'd be more close? And she starts to cry and says, I've always wanted to be more close. I don't know what's wrong with me, and I don't know who to go to. If you have that endpoint, then a sexual medicine physician should be where you go.
So, I mean, writing a prescription for the 67-year-old without his wife in the room or without that discussion is really not doing somebody a service.
Well, it's not the broader view, clearly.
Right, and that can end up with problems. We've talked about the older folks. You alluded to the younger folks with problems like the bicycle riders.
Oh my God, these poor kids.
San Diego, everybody here bicycles. And I hurt my knees recently. I've been advised that I should be doing more cycling. Tell me what I need to know about my bicycle seat. What's it going to do?
Well, you're sitting on your sit bones right now.
Yes.
So if this seat were just this bar rather than the seat, then that's what you do when you ride your bike. It's not wide enough. You can't sit on your sit bones.
Okay.
So you sit on the undersurface.
What's bad about that?
Oh, but the nerve and the artery to the genital tissue is there, and you actually crush it because it's the lateral border of where the bone is, where the artery is a bone. So it gets whacked.
Men and women?
Men and women.
Men and women. And how long a bike ride, or how much bike riding, when does this become a problem?
Well, so you have two issues. You have the chronic riding, banging on the artery, and then you have where duration of riding is a risk factor. But then you have the fall. You hit God bless the person who invented that 1-inch piece of steel, which is like 1 micron from your crotch area. You sit and you fall, you go whack like this. Right. You don't have to ride for 40 years.
No.
It's just a one-time item, so that's the issue.
Okay, and so why isn't every bicycle seat built so that this doesn't happen?
Why is it that we don't know to go to a sexual medicine doctor?
We require bicycle helmets,
issue?
for goodness sakes, when people ride. I mean, we do all sorts of safety things, seatbelts, et cetera, et cetera, et cetera. Why would we allow bicycle seats to be built that can cause this kind of damage?
Yeah, so I'll just bring this question. If we think there's something about 5 or 6% of bicyclists become permanently impotent while riding bicycles, those are our data. If 5 or 6% of people who went to a food shopping place and drank something that you bought had a medical problem, how long do you think that would be on the shelf?
You know, I'm waiting for the lawyers to get involved. You know?
Well, the thing is, people are so religiously fervent about how wonderful it is to ride, how exercise, how fit, how healthy they are. They don't even care that their penis is numb. They don't even. A lot of people don't even care they're impotent. Okay. This is their life. That's their choice. But the problem is a family. You know, you go out, you fly to Hawaii, and then you go bicycling, and you rent your equipment, and it's not the same stuff, and then the dad gets impotent. And he's never been told that could happen, never been warned. The bicycling magazines don't talk about this at all.
And it's a problem. That way. Right. Okay. So we have a couple other things that come up, and we don't have a lot of time because we've been talking about all this other stuff, so I want to make sure we hit these. Premature ejaculation, and anticlimax, loss of sex drive we've talked about, and then dyspareunia.
By the way, I have good news for you. I just came from an advisory board meeting, and there's now a drug that's going to be FDA approved for dyspareunia.
Okay, so let's explain what it is.
What it is.
Yes.
So it can happen, it's primarily in women, but it can happen in men. During the physical penetration, it isn't this pleasant, wonderful, joyful.
It hurts.
It hurts. And it's hard to be engaged in sexual activity when it hurts. And women are fearful of telling their partner. They live with this pain. I had a woman who walked in and she said, I'm here for low interest. And we do our physical, and I'm using Q-tips and touching certain sensitive parts. And she jumps. I said, you didn't even mention you have pain. She said, I thought it was normal that you have pain during sex. I've had it all my life.
Wow.
Yeah,
that's a big deal.
And women are fearful because they don't want their partner to not want to have sex, because that person expressing sex is how she believes he loves her.
And they also can't control it. I mean, the pain is hardwired into them at that moment. It's not a choice to have pain on sex.
No, God, no.
Right, okay. Premature ejaculation.
It is actually the number one problem with sexual issues. Sort of a funny problem, because a guy gets his ejaculation, gets his orgasm. So it's not always his issue. I mean, if he ejaculates within 20 seconds, 30 seconds, it's really an issue with the partner. She has no chance, no opportunity. It's extremely embarrassing. Right. We don't yet have FDA-approved drugs for it, but we have very rational, logical therapies, and we can really help people who have this problem. But the other end of premature ejaculation is inability to have orgasm and ejaculation. Yeah, so that's a huge problem.
Is that more for men or women?
Men and women. Everything is men and women. We always think of...
I just was wondering who, if there's a disproportion of one way or the other.
It's a big problem in older men, and it's a big problem in women throughout their life. And again, things like birth control pills, things like psychological issues, hormonal issues, blood flow issues. You need to figure it out and get treatment.
There were some simple questions that came up while I was preparing for the show. And one of them came up was, how long is sex supposed to last? You want to know? If sex lasts 2 minutes, that's not premature ejaculation if you get 2 minutes. I mean, if it lasts 25 minutes, is that too long and you're taking too long and you're having anticlimax? Yes, let's educate.
1,000 couples. We pay each member of the couple a stipend, $400, to have intercourse twice a week for a month. So we have several thousand data points. So what do you think?
Well,
7.3 minutes.
I would have guessed between 5 and 10 minutes.
7.3 minutes is the average, but really it's a wide variable, and it goes up to 20 and 30 minutes. What's fascinating is part of that study was to find out when women were satisfied. So women, the longer this time goes, the women are more and more satisfied until a certain time,
and then it goes too long.
And then the longer it goes, the less women are satisfied.
How did you have any trouble? Basically. Did you have any trouble? The women, no, of course, we do that. Did you have any trouble getting married couples to have so little or so much sex, depending on how you define it, twice a week?
This was real easy to recruit trouble.
Okay, so that wasn't any difficulty there.
No problem.
Do you run into those issues of married couples, frequency, all those kinds of issues of
huge? Yeah, I mean, that's disparate libido. So someone says...
The classic Woody Allen scene
right.
where we have sex so
great,
often it's
Woody
only
Allen.
3 days a week, and the other one says we only have it 3 days a week. I mean, does that actually happen?
Of course it happens. And one usually thinks that the guy is interested, and the woman says, I'm tired, I have lunch to make, I have to do the laundry, I have to make the beds, I have to pack, I have my project, I have my computer work to do, and okay, we have 10 minutes. If you're not ready in 10 minutes, we're done. Right. The last two people with low interest or this disparate libido were guys, and the women were saying, "What's wrong with him? You know, I'm interested all the time, and he's not interested." So actually, it's a both thing. And the good news for women is we have a drug that's being developed for women with low interest. It's very close to being at the FDA and that decision making. That'll be huge. This will be the equivalent to the pink Viagra thing.
All right, in the very few minutes that we have left.
Well, first, thank you. Thank you for inviting me. Thank you for talking about this field. This is not easy. A lot of talk shows don't do this stuff because it's the taboo thing. You're doing kind. This is awesome, and I appreciate it.
You're very kind.
I wanted to get that out.
Doctors should be able to talk about this stuff. Everybody should be able to talk about it, but thank you. We only have about a minute left, so I want to give you a chance to paint the world according to Goldstein. If you had a chance to decide how this would all work, what would happen when couples have problems, what would be the dream ideal that you would set up, that you'd like to see going forward in the future, that people would be able to achieve?
This is easy. UCSD and all medical schools all over the world would have as part of their curriculum sexual medicine, that this would just be yet another medical problem. Gee, I have difficulty with orgasm. Oh, sexual medicine. Oh, I just call that guy. Well, there's 4 of them. Let me call that guy and get my problem taken care of. Why don't we have this?
Well, that's a simple enough answer. And so you're building the future at Alvarado. That's what you're essentially trying to do, is set a standard that people can see that this does actually work.
I certainly hope that that's happening.
Thank you so much for your career, for everything that you're doing. And I look forward to catching up with you at some later date so we can continue to go into detail. I hope that this has been of some education for you guys. I've been talking with Dr. Irwin Goldstein about sexual medicine and the problems that go along with it, the red flags that might come up, and hopefully you've learned something about this, because the changes that take place in your body that allude back to sexual activities may be physical, may be psychological. They may have a much broader range of issues than just simply what's going on at home. You need to talk to someone who knows what they're doing. You need to be educated, because knowledge is power. I'm Dr. David Granite. Once again, this has been Health Matters.